Public dialogue and civic engagement are important. They play a role in improving the health and well-being of Texans across our great state. That's why Blue Cross and Blue Shield of Texas is proud to support Texas Tribune events like the conversation you're about to see.
Please join me in welcoming the Honorable Donna Howard, Susan King, and J.D. Sheffield. Great. Thank you all for being here. I realize that we're still paying you $600 a month, but outside the 140 days, you're not obligated to do this sort of stuff, so I especially appreciate your willingness to come down and be with us today. So I want to take you back to the beginning of those 140 days. When we heard about the priorities of this session and the priorities that our elected leaders had for this state. Heard a lot about transportation, heard a lot about border security, heard a lot about guns, heard a lot about tax cuts. Didn't hear very much about health care, even though health care will, in this next biennium, be for the first time ever the #1 line item in the all funds budget in the state of Texas, passing education, even though we have the most people in the state without health insurance of any state in the country. It was not an emergency item when the governor announced his emergency items. It was not mentioned in his inaugural. It was not mentioned in Dan Patrick's inaugural. Governor talked about this in the state of the state, a little bit of mental health and a little bit of women's health, but nothing about the big, nasty problem of the cost curve or of access to care. Representative Howard, why was this not item #1 during this session, given those challenges?
You're asking the Democrat.
I am. That's what we call a layup in the journalism business. Why was this not something we talked about at the beginning of the session?
You know, I am hard-pressed to come up with an answer to that question. You know, clearly it is, as you say, a huge driver of our budget. And we also were hearing during the interim, and we had been for quite a while, from chambers of commerce throughout the state, that we needed to address that issue for property tax reasons, for workplace reasons. There's a large constituency out there that wanted us to address it.
Right.
And it was not brought up. And in fact, the only legislation that was proposed, there were several bills proposed to address Medicaid expansion or the state exchange or whatever in dealing with the Affordable Care Act.
Right.
None of those got a hearing. None of those got a hearing.
And you think it's politics that is the reason?
Certainly it was not something that was indicated as a high priority.
Right.
And I mean, I don't have any reason to give other than politics.
Right. Representative King, why shouldn't politics be the driver on this issue? 98 Republicans out of 150 in the House, 20 out of 31 in the Senate. Every statewide elected official is a Republican. Elections have consequences. This is a conservative state. Why would we entertain something that our elected leaders don't want?
Well, I think that really the Affordable Care Act and everything done at the federal level, and there's continuing fights up there,
right,
that maybe people are fatigued by the topic of health care and they don't feel that the state has to enter in. The decision was made when Governor Perry was there not to expand Medicaid. The also decision was to have to not set up our own exchange. So I think
Indeed.
Largely people look at that askance and they don't look at the big picture as much until we have things pop up like women's health and changing the funding, who's doing it, who's not,
right,
and different things like that. So I think that's really what happens here.
Yeah.
And I think the red meat issues for many people tend to be the things they can see every day, you know, transportation and
right,
others.
Border security.
Yes, border security, because of all the unaccompanied minors that came, but now it's decreased, and all that going on, an unprecedented amount of money, $800 million, to
right,
deal with a problem that many people say is no longer the case. But then if you read different things such as crime intervention and different things like that, you see that it really is a difficult thing. You get to things like human trafficking and drug cartels, et cetera, throughout the state. But I think there's some fatigue, quite frankly, there.
Yeah.
And, but I'm grateful that we did make some really good things with GME, et cetera, because that's the practicality of it. You know, we can sit there and bark all we want to about access and can people get care, but if you're not the people doing it, if you're shipping your people out to other states, which
right,
everyone knows all this, it's really a bad policy decision.
So part of addressing the shortage of care is addressing the shortage of providers
Absolutely.
of care, and so we need, and we'll come to what was done during the session
Right.
to
And one thing,
address
just
that.
one tiny thing I want to add that I think was important, that I had access to discussing in an interim committee that I had, and I almost said Senator, Representative Howard was also on with regards to healthcare workforce, and then chairing the Defense Committee. What happens is we see that the mental health component, which globally people don't even talk about unless they've had an experience there, is really critical, and it's the most underserved subspecialty.
And this was another session, we'll come back to this. This was another
sure.
session in which mental health was a winner.
Yes,
as
absolutely.
issues under this umbrella go.
Very much
Let
so.
me come at this, Representative Sheffield, another way. So we know from the Episcopal Health Foundation out of Houston and Rice University, the study they did of the impact of the Affordable Care Act on states. Texas, pre-ACA, was at 25% of the population uninsured. Today, we're at 17%. So we've dropped a total of 30%, but 8 percentage points, 25 to 17%. We still have the most people without health insurance. The fact that we didn't create a state exchange or do anything else to embrace the Affordable Care Act is credited for that drop not being steeper. Do you think, as you look back over these couple of years, maybe we should have entertained some engagement with the federal government on this and therefore maybe seen some better or greater results? What do you think?
Let me explain how our district felt about this back when I ran 2 sessions
Back in
ago.
your district, yes.
Yep.
Yes.
Until we have enough representatives elected with their platform being health care improvement across the board. Until that happens, we won't have a critical mass of effort in the House of Representatives to get that moving.
Right.
So in our 8 rural counties, our primary reason for running was to improve health care, to help patients across the board.
Right.
Whereas in the Capitol building, it's almost a hot potato to touch because they'll always try to tie in Obamacare and Medicaid expansion, which because of the politics have very negative connotations for anybody who wants to approach that to just work on our uninsured problem and make it better.
Is there any way that we can rebrand it? Can we call it Sheffield Care? or Abbott Care? I mean, I don't know that we need any one name particularly, but is this really just a political issue at that simple level?
There is a great deal of politics in that with the name of Obamacare.
Right.
That is true.
Yeah.
And
We did have an
right.
attempted solution that was called
Right.
the Texas solution or Texas way.
Right.
Yeah.
But also, just the phrase Medicaid
Right.
sets off a lot of people in the House and the Senate.
Right.
That's bad for Texas. So since it's bad, therefore, we don't have enough momentum to get in there and fix it and
Right.
make it better.
Yeah.
So I think that's going to have to change in the House and in the Senate before improvement can be seen there.
Right. Representative King, the question of the costs of health care in Texas, hockey sticking, finally passing education. Did we do anything, in your estimation, over the course of the session to try to get a handle on the cost curve? Are we any better off now at the end of the session than we were with regard to health care costs?
Well, I know that the veto pen with Governor Abbott took out about, what, $300 million, and that did take some care away.
Some of that, right.
So quite frankly, I don't think we did anything substantively, no.
Yeah.
I don't see that we did. There are some people that are trying to regroup, and for example, in women's care, I mean, that's newly off the press, to be able to have other people take care of women for screening, breast and cervical, et cetera, but as far as costs, no, I don't think there was anything substantively done. I was not on Article 2, which is, of course, the healthcare side of
Yes.
appropriations, but it didn't seem like, there again, like Dr. Sheffield said, it just didn't seem like that was a topic that anyone was really concerned about. And I do think that it is a lightning rod with the Affordable Care Act. And quite frankly, when you said if people got together, my understanding when this was all put together in Congress, that the physicians that might have, and I don't know if there are any nurses in Congress, do you know? But there are? Okay. So I was understanding that those medical professionals who would have the most to gain and the most insight were not in the room when that was formulated to a certain extent. Is that hearsay? Was that true? But I certainly have heard that many, many times. So I believe that that's where it began, the federal and the state. It is a lot of bravado to say we're not going to do this, it's unsustainable. A lot of economists have said that you cannot continue to go to the expansion level. You know, is it money on the table, is it not? I don't know that we really have any money on the table anywhere with regards to our debt. So, It's not an easy answer. But I do agree also with Representative Sheffield. It's a toxic word to hear Medicaid. But quite frankly, I don't think there's anyone in the House or the Senate who has Medicaid. Would you agree? So for that having been said, it's a different population. You know, we're more of a bubble than the people that take care of patients, you know, and see the Medicaid population that's coming forward. So I would say that would go on the list that we did not substantively address at this time. I certainly would agree.
But Representative Howard, to this question of the growth of Medicaid, my understanding is that Medicaid is growing 2.5 times faster than any other part of the state budget. In 1989, it was 12% of the budget. This year, it's 29% of the budget.
Well, if you cover some more people, you're going to expend more dollars.
Right.
And one of the things we've done is we have covered more people over the years.
Fast-growing state, it's
Yeah.
probably predictable that you would have to cover
Exactly.
more people. Right.
I do want to say that we're House members up here. I know our Senate colleague here in the audience. I will say I think the House did a better job with the budget. And in particular,
House members always say that, don't
yeah,
they?
we do. But this is actually true.
Right, well, you're not arguing with that. You agreed this morning, you did.
Okay,
Well, one of the things that the House did, for instance, was the House proposed taking the Medicaid payment rate up to 100% of Medicare.
Correct.
The
And
Senate
that-
wanted to keep it at 65%, and the Senate prevailed ultimately in the budget that was passed.
Correct. And if we're talking about a so-called broken system, which I still don't have a clear understanding when people say that, what they mean. The only thing I can ever nail anybody down about is it's broken because we don't have sufficient providers and access.
Right.
And one of the reasons we don't have sufficient providers is because of a state decision, not a federal decision. The state decides about the reimbursement rates here.
Yep.
And the Affordable Care Act temporarily increased the rates for the primary care providers. We had an opportunity, and the House chose to be responsible, in my opinion, and provide almost $500 million to get the reimbursement rates up to the Medicare levels. And the final budget did not include that. I think that was a huge mistake. I think it was setting us backwards, and you're talking about affecting the cost curve.
Right.
Having the providers in place to actually provide the services would have been very well worth that investment, and we had the dollars to do it.
And you both, Representative King, Representative Sheffield, supported the House budget decision to take that payment rate up to 100%.
There'd be no reason not to, especially since typically or stereotypically that the Medicaid population is more difficult. Plus, it's all or nothing. You don't have, you know, something
Right.
coming back in on the other end like you do with Medicare with whatever the Medicare didn't spend. So there's no reason that shouldn't be in parity, you know, because you shouldn't be parsing out, in my opinion, what program it is that's paying for someone if you know, it's already, what, 25% of what you would charge with private insurance. It's a huge,
Right.
a huge cut in the
Right.
amount of money that a provider would get. So,
Right.
so to bring it up to parity with Medicare was a logical decision.
And Representative Sheffield, we're already down to only 34% of physicians in Texas taking new Medicaid patients, which I believe is a historic low. That reimbursement rate question might have actually helped to stem that decline, or maybe even raise those numbers back up a little bit.
Absolutely.
Yeah. You have any sense as to why we didn't take the House's position on this? Was it a matter of budget, or was it a matter of, was it economics, or was it politics?
Politics.
You think it was politics?
Absolutely.
Any disagreement about that it was politics?
I would dare not speak for the Senate as a body.
Oh,
but-
dare. Dare.
Sorry, not going to do
I'm
it.
sure the Lieutenant Governor has no one watching the live stream. Go ahead.
Yes,
No, you wouldn't dare say it. I think you think it's politics. You've actually said so, right? This idea that the federal government may withhold the $29 billion from hospitals, the waiver, if we don't do something about Medicaid. Do you take the federal government, Representative Howard, at its word that we're at risk now of going into a further a spiral downward if we don't do something? Or is this an idle threat by an administration in the second half of its second term?
I don't think it's an idle threat, but I also think that the federal government has said that they're willing to work on this with us, that the 1115 waiver that you're talking about, I think here.
Yes. Estimated to be worth about $29
Right.
billion to hospitals over 5 years.
I think it's important to remember that that was set up at a time when the expectation was that all of the states were going to be expanding Medicaid.
Right.
And that this was supposed to be transitional dollars. It was supposed to help ease the transition of more folks coming onto the Medicaid rolls so that states could build up capacity.
Right.
This is not supposed to be an ongoing funding stream, and it's certainly not supposed to be addressing all of the capacity needs that we have.
It's a Band-Aid.
Right, and so I think it's a fair thing to talk about how do we continue this waiver with some effort to expand, whether it's expanding Medicaid, the Texas solution, whatever you want to call it. How do we talk about Texas doing a better job about expanding the coverage
Right.
of Texans? You know, I know that we're already making some efforts. I know that folks have been going to Washington and trying to address this in a bipartisan way, that it is critical that we get these dollars. It will make a big difference to
Right.
the care that's given in our communities. It'll make a big difference to our hospitals.
Yep.
And so I think it's critical that we get it. But I also think that in good faith and trying to find solutions rather than just bashing the feds just for the heck of it now, because that's the standard knee-jerk reaction, that there are some things we could be doing that
Right.
could make this workable.
Well, Dr. Sheffield, the reality is we're in a presidential campaign. We're in the second half, as I said, of a Democratic administration, Republican Congress without a veto-proof majority. The likelihood is not much is going to happen over the next 2 years on this and a lot of other issues, so we need to turn our attention to what we can do in the state to address this problem. And I want to ask about what Representative Howard brought up initially, and that is the shortage of doctors, shortage of providers. Graduate medical education work that you all did during the session is helpful. The creation of a medical school in Austin and a medical school in the Valley will help to some degree. What else do we need to be doing to increase the number of providers of health care to our citizens? What did you do and what can we do?
What we just did, what you laid out, was an excellent first step.
Yeah.
And then we need to go back and address two issues.
Yes.
First, the people who we admit to medical school. We need to look instead of the best and the brightest, of those who are bright enough to pass medical school, but more importantly, care about taking care of patients the rest of their career.
Yep.
And we need to get away in healthcare, in the physician field, about looking at incomes and lifestyles as being a factor there. We need to get back to doctors who care about taking care of patients their entire career, because everybody should see the handwriting on the wall about healthcare. The money is not going to be there in the future like it is now for salaries. And I tell these students and the residents and the interns that I'm in connection with, you need to be thinking about taking care of patients, not your lifestyle and income. Second,
How do you persuade them that that's the way they should be thinking about it?
you can talk to them at
It's
that
a big
point.
challenge, isn't
Yes,
it?
you can talk to them at that point.
Yeah.
The more important of the point is that's who you admit to medical school
Yeah.
in step one.
Right.
Those who are coming in because it's a caring profession.
Right.
Easier said than done, I agree. Now, the second part to that question, the second part to my answer, we need to swing back in this entire state to primary care. And I was speaking with the leaders of this facility before here.
Yeah.
Family practice, pediatrics, general internal medicine, OB-GYN. We need to put out more of those, and we need to direct as much as possible those to the rural and underserved areas.
Is
Those
this
are my 2
connected in
points.
part to the first point you made, that in the specialties there's the opportunity to make more money, and so people are choosing those specialties as opposed to the opportunity to become a GP?
2 issues there
Yeah.
that I learned talking with the specialists, because
Yeah.
I'm family practice after all.
Right.
Number one, the money is there. The nice fancy tools and toys and gadgets are there.
Right.
And they're on the cutting edge of medicine a lot of the time. That's a very interesting, rewarding place to be.
Right.
Second point, now more than when I came through medical school, when medical students graduate medical school and internship and residency, they have an incredible amount of debt that people of my generation just did not have. And so when they're looking at trying to pay off that debt, it's only human nature they would look towards the higher reimbursement specialties and practices.
Right. Representative King, Representative Sheffield talks about the idea of rural areas of the state are really in need of providers. We're a rapidly urbanizing state, but there are still big populations outside the big cities that are short of providers. What did you all do this session, or what can you do going forward to try to address that particular problem?
Well, you know, we've had loan repayment in the past and certain subspecialties that would encourage them, but after the fact, you can't keep them there forever.
Right.
So you could stay there for the period of time to have your loans repaid and then leave. And quite frankly, you know, you either like rural Texas or you don't. I mean, it's really different. And, you know that we have 75% of the land mass and 25% of the people. So it's an engaging problem. But I have to say to Dr. Sheffield that to try to figure out how to measure if someone cares about a patient at the outset or at the entry point is like trying to tell the legislature to have common sense. How does that work? I don't understand how that could work. I understand what you're saying, and it enrages me to see someone that doesn't care. But you cannot do that. I don't know how you do it. And maybe there's a subjective way that we would see it.
It's hard to change human nature.
Absolutely, and it's always traditionally been the people that are best and brightest and smartest that can do the Krebs cycle and pass the MCAT and all that stuff. But yet at the end of the day, I think that a lot of doctors leave their profession if they end up being not really engaged with people, because it's not a fun thing unless you're doing plastic surgery on someone that wants it. You're having to deal with problems, and that makes it a uniquely different specialty.
Representative Sheffield talked about nice tools and gadgets that some have access to in different areas of medicine. The reality is technology may be an answer to this problem in a general sense. There was a discussion about telemedicine during this session. You know, is technology an answer to trying to address access to care in some of these harder to reach communities?
I think in some ways it is, and Dr. Sheffield can speak, because I don't know if you have any patients on telemedicine, but you know, there is no substitute, in my opinion, for a face-to-face encounter with the patient. I mean, you can do the sim labs, you can do robotic surgery, you can do everything else, but you know, I'm sorry, I have a friend that says, when all else fails, look at your patient. And I feel that it's really, really important to make sure with the telemedicine it's indicated in some ways, but there's been some problems with, you know, what type of drugs you can, you know, prescribe. There's been problems with DPS, looking at all those things. So it's not an absolute panacea, but it can change in some ways if, I think, in my opinion, you've had an actual encounter with the patient first. I don't think you could begin your whole patient-physician interaction online. It'd be like getting engaged to someone you've never seen before.
Which happens.
I know. I'm sorry. I can't go. I can't do that. But I think that's part of the thing. So I think there's all kinds of things we can do. But are they sustainable and long-lasting? I don't know.
Representative, I'm thinking about patients in the Valley. The Valley is a place that has historically not had the same access to care as some other places. You have a cancer patient in the Rio Grande Valley who all of a sudden may be able to access the specialties and the expertise of an MD Anderson Cancer Center electronically, you know, through telemedicine. That just, at least theoretically, seems like a no-brainer. Why wouldn't you try to figure out if you could make that kind of service available to people?
Well, and we had discussions in some of the committee hearings about the correctional system and the healthcare in that system was using telemedicine. And it was an effective way to expand healthcare coverage. Certainly you want to have the quality built in there. I mean, there's no question what Susan's saying is absolutely correct. You know, you need to have the face-to-face as well. But, you know, in a state this large, with the rural access, the correctional care facility access, all of the challenges we have, to not allow some optional ways to deliver care is basically choosing nothing sometimes. No care. And so how do we use the tools in such a way that expands the access and maintains the quality? And of course, one of the things that comes up a lot is the use of APRNs and physician assistants. And
so this is the scope of practice. This is
that's the term that's used that usually red flags everything, so you can't have the discussion.
There's been a big fight the last two sessions about whether we ought to be expanding the pool of people who are in the room, as it were, to provide care. Why does this continue to be a fight? Again, what is I mean, you're obviously coming from the perspective of somebody who has been a nurse. You understand this issue probably at a level that many of us who are not professionals don't. Help us understand what the fight is over on that.
Well, I will probably defer that to Susan, so she and her husband could probably talk about this.
Don't bring him into this.
But no, and her husband's the president of the Texas Medical Association.
Immediate pass.
Immediate pass, whatever. You know, there's legitimate arguments, I think, to be made. It's not like there's no credible discussion here on both sides. I think the big issue here is, let's see how we can get the emotions out of it, the politics out of it, the knee-jerk part out of it, and talk about what's responsible healthcare delivery. And APRNs in many other states are practicing to the full extent of their license and training and doing quite well, and the studies indicate that the care is every bit as good as what they were getting from primary care physicians. This is not about replacing physicians. This is about expanding.
It's both
the
and, not
capacity.
either or. Is that
That's
right?
correct. And you know, we are doing with the GME and so forth, we are trying to expand the number of physicians that we have that stay in this state and practice here. And we want to keep doing that. That is an extremely important thing for us to do. But if we were able to do that and get as many docs as possible, we're still not going to meet the need that we have.
Right.
And so to prevent our looking at these other options that can still provide quality care, to me, is not really the solution.
Dr. Sheffield, is there an acceptable level of armistice on this scope of practice question from your perspective?
Before I answer that question, can
Yes.
I back up to another issue she and I were just
Oh,
talking
most
about?
sure,
Please,
sure, of course.
please. She is exactly right, representing exactly right about how you look into the mind of someone applying to medical school. During my medical school rotations, I went back and sat on one of the committees. I watched them go through that process. It's an incredibly tough process. And one of the people said, you're just trying to find out if these kids want it enough to do the work.
Right.
And what they said was, we've learned that just trying to get the science nerds, chemistry, biology, and all that,
Yes.
we want to find the people who have that humanity streak in them, to care for people. Very hard to do, very hard
hard
to
to
read.
know,
Yes.
yeah.
The second thing between primary care like me and surgical specialties like her husband, both of them have incredible fulfilling moments.
Yeah.
For instance, primary care, as one of my professors in residency said, I asked him, why you pick primary care? He said, well, you go into primary care because you like people. And you're going to be there long enough to where you make friends with your patients, you're taking care of several generations of the same family, and before you know it, you've been there long enough to where I go to work and I see my friends all day long.
Yep.
That's primary care. Now, the nice toys and technology with a specialist, I was speaking with a lady who works here right before this meeting. She gave me an example of her brother who has pancreatic cancer. When I started 20-something years ago, pancreatic cancer was a death sentence, and it still is for a lot. But the physician for her brother was able to take some brand new technology,
Yep.
go in there, incinerate that cancer, and maybe cure. Now, for the specialist, that's got to be one of the greatest fulfilling moments possible.
Right.
So there's room for both of that.
Yeah.
So I'm not knocking specialists because
Right.
they are on the cutting edge. That's an interesting place to be, got to be. So I wanted to say that. And then the armistice issue. Been involved in that. I work with mid-levels in our practice.
That's a problem, that
Yeah.
term, but keep
Mid-levels?
going.
Right.
Yeah, we don't
Yeah.
really like that term.
I know.
Go ahead, go ahead.
I'm going to let you all have this out. So
Well,
I'm just going to sit here while
and
you're-
she and I both agree that we're getting tired of the terminology
Yeah.
in our medical profession. I like to be called a doctor, not a primary care profession
Right.
or primary care provider. They don't like to be called mid-levels. Let's call them physician assistant or nurse practitioner. And I agree with that. It seems like between government and insurance and all this, we keep getting lumped into this one group with the same title.
I guess the question is, are you comfortable with more folks who you refer to in quotes as mid-levels being given access to providing care and to ultimately up the number of people in the room to provide greater care for people in the state?
I support the way in which this started, in that the PAs and nurse practitioners are part of a team
Yep.
working under the supervision of a physician, and it is also on the physician to supervise appropriately and to train. And so there is a place for that,
Yeah.
I believe. And especially where I come from and where we are now, we have a shortage. And the PAs and nurse practitioners help fill that
They
shortage.
play a big role. Well, it's in a community like yours where this problem is probably the greatest. Representative King, you talked about mental health. Mental health had a good session in 2013, another good session in 2015. There seems to be finally a recognition across the entire legislature that we have underfunded mental health services in the state for a while, and we're now playing catch-up. That's a good
I would
thing.
agree. Not only that, but the providers. And certainly, no matter what happens, ever in the whole history of anything, the stigma cannot be completely removed.
Right.
And people do not understand that physiological problems and mental health problems are in the same person, in the same body, and they have interface with each other. So it's just not a real desirable profession for some people, psychiatry. And so when you talk about mid-levels or ancillary personnel.
You said that word, I didn't.
I know. I'm not going to get into it, Dr. Sheffield. So anyway.
Right.
A mid-level is a tool with that little bubble, and you look at the midpoint in it, that's a mid-level. But anyway, so the point being is, if you have a team approach and you look at the way that these people are taken care of, you're going to make a difference. Does it mean that we're going to skyrocket loan repayment for all psychiatrists? Probably not.
No, although that was something that you all looked at this session.
But there's some really innovative things that are happening in the veterans world, peer-to-peer, which are people that, they're veterans, and veterans tend to really appreciate, and they've been in a situation with understanding that another veteran understands what they've actually been through. It's a unique situation. I am not a veteran, so I can't tell you, but by watching and listening and having people talk about it. So things like that are more innovative that are going on, and we have to look at every single way to have a touch point on these mental health issues. The VA says there's 22 suicides a day, but their data, not to bash the federal government, to me is abysmal and incomplete. So is that true? I don't know. What do we know about the causes? We don't, because you typically can't ask a person why they took their own life. So, but we're making some strides, quite frankly, and a lot of things in prevention. And so I think for that respect, people are finally looking up and saying, wait a minute. And it's not just people that are maybe abusing drugs or alcohol that are down on their luck and they might take their own life. It's people, everyday life, people, heroes in military. So it's something we have to continue to look at.
And Representative Howard, mental health funding, the whole portfolio of issues around mental health are actually the rare bipartisan issues in this legislature. This is a place where everybody does come together. Whatever else they may disagree on, there seems to be agreement across the board that this is an important thing to look at.
Oh, absolutely. It was Dr. Schwartner on the Senate side who had the legislation that provided the tuition reimbursement for
The psychiatrist.
for mental health professionals, including psychiatrists, I think.
Yeah.
Did it pass?
But yes.
Yeah,
Okay, but there again, there's another scope of practice issue with not everything passed, that people felt that they could be a mental health augmentative type of profession. Those didn't go. So you're still going to always have that. I don't know if there's a moratorium for a while that doctors and nurses, we're just not going to bring it up. And so, but I don't know if it ever actually has been brought up, person to person, table to table.
Well, there's certainly more attention on it after these last two. Another thing that you all were able to accomplish, not to the degree that you thought you would going in, was the consolidation of the health agencies. The initial plan was to consolidate the 5 big agencies. Ultimately, because of the contracting reform questions that came up at the beginning of the session, you made the decision to consolidate 3. Will any of us out in the world feel the effects of this? Is this just basically less red tape and less bureaucracy? What is the impact, Dr. Sheffield, to the average Texan of consolidating health agencies?
Not having sat on Sunset Commission, I don't have an answer from behind that table. What I understand is that when the Sunset Commission was looking at these agencies, they found overlap and duplication of efforts. And in trying to eliminate that, then the idea is to have more funds to work with, and better outreach.
So we'll have some cost savings.
Hopefully, that's the idea, sir.
Right. Representative Howard, do you feel good about what you learned about these agencies, the way they operate this session, that we don't need to do more significant overhauls of these agencies?
I think that's a good question that I don't know that we have a good answer to that.
And some of this will be studied during the interim.
Right, exactly. The thing that I was going to mention specifically about that, though, had to do with the women's health care and the consolidation that occurred there.
Right.
We basically have had 3 programs delivering women's health care, and that was consolidated this time so that we have 2 programs, and they're now all in HHSC and nothing at DSHS. I did get a rider through, or actually this was an amendment, I guess, on the Sunset bill, that will require that the providers of those programs be a part of the transitional team to give input into how this is going to logistically work.
Right.
Because there's a lot about eligibility, there's a lot about which particular benefits are going to be available, and you know, this is a system that has gone through a lot of change in recent years, as you
Right.
know. And so
And it's also, like the Medicaid question, as much a matter of politics as it is anything.
absolutely, and,
Right.
and in 2011, when the budget cuts occurred and when family planning was cut by 2/3 and essentially wiped out over 70 programs in our state, the intention was to prevent Planned Parenthood from providing services, but the unintended collateral damage was wiping out a bunch of other programs as well. And it's taken us a while now to shift back and rebuild the safety net that we've had.
Are you there? Is the safety net adequate now?
You know, where we are, we put $50 million more into women's health care this time, which is good.
Right.
From what I understand, if you look at the clients who are served, and some of these programs serve men as well, the clients that are served, we are probably meeting the needs of about 1/3 of those who are eligible. That's what we were meeting before the cuts, though, as well. So we've worked back up,
Right.
basically, to providing services to 1/3 of those who are eligible. And these oftentimes are programs, as we know, that we have real strong outcomes about that are not only healthier health outcomes, but also the fiscal outcomes. It has a huge impact on saving taxpayer dollars.
Yeah.
Specifically, if you're talking about unplanned pregnancies, the cost of providing a year's worth of care to prevent that pregnancy versus a year's worth of care and beyond to cover the pregnancy
Post-pregnancy,
and
right,
prenatal, yeah, is obviously significant.
Representative King, this is obviously an issue that politics is loath to settle. And it's a bit of a Rashomon deal. Different people look at the same set of facts and tell the story differently. Are you satisfied that with the work that Representative Howard is talking about over the last 3 sessions, there are enough providers within the women's health program to address the need in this state? Have we done enough?
Well, if you're saying if everyone that needs services is getting them, you know, whether they're on Medicaid or if they're in an uninsured situation, they're getting through a faith-based clinic or whatever, I can't really speak to that. And for me to say we have enough would be irresponsible, especially with our huge growth every single day in the state of Texas. So,
But the additional money that went into the
yeah,
program.
I think it's important that we continue to add money because we have continued
that's a good
population growth. So I think that to not look at, no one ever talks about men's health care issues, quite frankly. I mean, you mentioned that they, you know, have.
Would you like to talk about men's health care?
Yeah, would you? Jay,
They don't get it. They don't go get it, okay?
They don't have
Men
time.
don't go get it.
Okay. Not entirely sure I want to go there. Let me ask you about one more question that sort of abuts health care and sort of doesn't. We legalized the use of cannabis oil in the treatment of epilepsy patients this session somewhat famously. Didn't go to legalize medicinal use of marijuana, of course did not go to legalize recreational marijuana. That may be the last thing we legalize in this state. Why are we not having a more serious conversation about medical marijuana, Dr. Sheffield, in Texas?
It's very simple. For years now, especially in the Capitol, anything that has the word marijuana is just as hot as anything that says Obamacare and Medicaid.
Is that right? So if we call it Sheffield Wana, is this going to be a case of it's going to be a case of changing the name again? Is that what it is?
Nope.
No, but the cannabis oil bill passed. Is it because they called it cannabis oil?
Partly. But sitting on Public Health Committee where that
Yeah.
came through, we need to give significant credit to Representative Stephanie Click out of the
Yes.
Fort Worth area.
Yeah.
She carried it, and it was almost an example from a textbook of how to get tough legislation passed. They had done their homework, they had done their legwork, they had the write-ups for it, they had the witnesses for it.
Right. And it was a bit of a Nixon in China moment, wasn't it? She was probably the least likely person to carry that bill based on her disposition on the issue the previous session.
That is correct. She
Right.
does belong to a more conservative part of the Republican Party, which with her carrying that, took away that issue.
Yeah, it disabled much of the opposition to
Yes,
it.
it did. But they also were able to put this forward in such a way that it brought out the headlines about the issue of medical usage of a plant
Yeah.
having prevented the abuse
Right.
of the same plant for the manner in which it's going to be given.
Right. So Representative King, is cannabis oil being legalized for the use of epilepsy patients, the nose under the tent here? Is this going to be the gateway drug, as it were, to legalizing medicinal marijuana in the state of Texas?
I don't think so, because I've seen Representative Neistat bring the medical marijuana bill multiple times.
Right.
I think the key word here is non-euphoric, and so non-euphoric indicates that you're not taking it for the purpose of getting high. But I think also that, as has been said, that the people giving testimony, when you bring an adult in with their child who's had intractable seizures, and they can tell you how many per day, the duration, and the impact, that's a really compelling thing to not say, to say no. This is a gateway. So I think because it's non-euphoric and it was children and it was specific to one particular type of clinical presentation, that I don't think it will be a gateway. And I don't know. I bet you've seen patients come sessions before with catastrophic things such as trauma and cancer and everything, and people saying, no, 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 you don't really have a problem. You weren't really in a critical car wreck. You don't really have end-stage cancer. You just want to get high. And I think that's pretty strange, actually. So in answer to your question, I said, no, I don't think it is. It's a unique, very singled out indication.
Isolated, carved out.
Yes,
You
yes.
agree.
I think that's right.
Yeah, and Governor Abbott has said that this is it, that he's willing to support this. He's not willing to support it moving any further. So I think I'm going to take him at his word right now that that's not something
That this
he
is
would get
likely to be
behind.
what's it.
Right.
All right, so let me ask you to line. We'll take Dr. Sheffield before we take questions from the audience, but please line up on either side. We'd be happy to answer your questions here in a second.
I was sitting on the Public Health Committee this session when this bill came through,
Yes.
and I wish to put forth two comments that parents made about this bill that just drove home this bill so much to us. One lady was saying, this bill means the world to me because it changes the world for my child.
Yep.
Very, very significant. The second
Compelling
was
testimony.
a gentleman who had picked up his family and moved to Colorado after traveling back and forth, and he said, my child has this disease that all of the specialists cannot control.
Right.
If you were in my position, how far would you go for your child?
Right. Let me go one side to the other. We'll take, again, as many as time permit. Ma'am.
Hello, I'm Olivia Thornton. I'm a second year now medical student here at UTESCA. And first off, I just wanted to thank you, Dr. Sheffield, for standing up for Texas women in the 20-week abortion ban debate back in April. And along those same lines, can you all comment on the role that women's health will play in the upcoming session and why the House is focusing on Title X and eliminating judicial bypass, both of which target low-income women and do not result in good health outcomes?
Wow, okay.
Some questions have a point of view, some don't. That one had a point of view. I'm going to let you all.
I'm going to jump in and say,
Okay.
we had, of course, the special session a while back.
Almost 2 years ago as we
Yes.
sit here, right? Yeah.
Yes, where we had significant restrictions put on access to a legal medical procedure. And pretty much, I think a lot of people thought, it's taken care of, won't be back, but sure enough it was. And I think it always will be because it's one of those issues that motivates constituencies, if you will. And so this session, we did have further restrictions placed on the judicial bypass for teens who have been abused and raped, who are trying to find a way to get an abortion without being further abused by those who are in control of their lives. And again, Stephanie Click had some legislation to make that a little better, and an amendment to not reveal the names of the judges. Give her a shout out for that. But it's something that's going to keep coming up, I believe. We had the unfortunate situation this time, too, of the breast cancer, cervical cancer screening programs, eliminating Planned Parenthood from being a part of that, continuing to use these ideological-driven motivations to impact the access primarily of low-income women. It's primarily women who don't have options, who are having their access restricted. Why it keeps going on, I don't know, other than we did have some legislators who will say up front and on the floor that until all abortion is stopped, they're not going to stop presenting this kind of legislation.
But Representative King and Representative Sheffield, interestingly enough, what Representative Howard says is true, but a takeaway on this issue from this session is actually that conservative groups, pro-life groups, consider it to have been not a particularly good session for them on this issue. They pronounced the legislature actually insufficiently committed as a body to this issue because a lot of bills that they had hoped would pass did not pass.
Right, and I think part of that was that many of the amendments that were in this area of subject to go through that people wanted to pass were attached to the Department of State Health Services sunset bill, and it became untenable at that time that if they all went on and not everyone agreed to it, what was going to happen? So they re-referred the bill to committee and stripped it down to being primarily regulatory. So a lot of these things where there were some votes taken, one being data points and reporting on the procedure of terminating a pregnancy. I think that some of those are not such bad amendments because it's so easy to give this big dramatic picture of what does and doesn't happen, and quite frankly, DSHS or Department of State Health Services doesn't really do a really, really strong data collection on that. So
right.
That's just an aside there. But I think that it will continue to be the claim that Representative Howard just said, until Roe v. Wade is overturned in some way, whether it through the U.S. Supreme Court or de facto with more and more regulations, I think that there is a group that feels that that's the most important thing to do.
Sir.
Irrespective of an exception or danger to the life of the mother.
I'm Robert Ludicky. I'm a physician in private practice. And the question I had was, one of the bills that Governor Abbott vetoed, as I understand it, was intended to help emergency room physicians who felt that patients were going to harm themselves or someone else to delay those people in the emergency room for a few hours so that they could be further evaluated and decide how to help them.
That's what the bill would have done.
Exactly,
Right.
but he vetoed it.
Okay.
From my standpoint, if one of my family members was felt to be a problem by the emergency room doctor,
Right.
I would be very, very glad for that to happen. What about y'all? I mean, would y'all want your family members
Dr.
kept
Sheffield,
there
you're
for
familiar
a few
with
hours?
this legislation.
Very familiar with the legislation, very familiar with the work. I've had to do emergency order of detentions on my own patients.
Right.
One patient I rode in the vehicle with him to the psychiatric hospital in which he was admitted. The root problem here is that Texas has underfunded mental health for so long, we don't have enough beds in our state for mental health, period. And having said on public health 2 sessions ago when you were there and we passed mental health funding, I got the feeling, right or wrong, it was because of all of the school shootings and other mass shootings that had occurred. And it was brought out that the people involved were suffering from mental illness. So all of a sudden it was front on people's minds.
Right.
And we were able to get that funding through. It's tragic that it has to take tragedies to have a change there.
Do you know what the governor's objection was to this bill?
No, I don't, because I supported that bill 100%.
Representative, you know?
I've not read the proclamation or the veto statement, but what I had heard during the course of the session is that how would a physician be given the training and the understanding to detain, which would be normally a prerogative or for law enforcement? To me, it just would be common sense. Physicians have to detain or restrain to help someone from hurting themselves anyway, no matter what you're doing. If you're looking down their throat or something they don't like, pelvic exam, for example. I just feel that my understanding is that there was a crossover between law enforcement and physicians. To me, again, it was common sense because if there is no facility to take them to immediately or they need further evaluation, it does become a de facto detention. So I don't understand. Perhaps the bill was not explained in more of a medical parlance to that veto situation. I don't know, but to me it seemed logical. But there again, we don't always pass things that are logical that would be helpful, especially in the realm of a very obscure thing when you don't want to put someone who is being evaluated for mental health problems and lock them up, put them in the back of a patrol car, and who knows where they go next.
Right.
And I agree with Sheffield with regards to, we just don't have the funding to have the availability, and we're putting a lot of burden on sheriffs and others to transport people. It becomes problematic on many levels.
Right. Ma'am.
Hi there. I'm Zoe Russell. I actually care a lot about the marijuana issue. I'm with Republicans Against Marijuana Prohibition, RAMP. We really exist. And I just wonder, I want to point out that Senator Menendez actually filed a comprehensive medical marijuana bill, and Abbott in his statement said he didn't believe conventional marijuana should be medicine. So I think there was some nuance in his quote. What do you think that patients with other conditions can do to receive some legitimacy at the Capitol on this, like cancer, severe pain, MS, PTSD? Right. And why do we depend on opioids and harsh prescription drugs that, you know, cause overdose deaths when cannabis doesn't, cause organ failures? Thank you.
So is the strategy here, Dr. Sheffield, to take the same lesson that Stephanie Click taught you all? It's all about how you pitch the issue? I mean, maybe it's possible that people who suffer from one or another of these afflictions can approach it in the same way.
Yes, it's about a pitch, but it's also about, in her bill, she made sure that it was known they removed the THC, the psychogenic, the addictive part of it.
Right.
So this cannabinoid oil has no addictive properties.
So would that be potentially a similar deal over here with some of these other afflictions?
Possibly, because as these two ladies have told me time and time again, you have to be patient in the house. It takes more than one session to get things done, which is hard to learn as a physician. But last session, well, you were on the Public Health Committee with me when we had the bill, Dr. Neistat, about marijuana being useful for end-stage neuropathy and spasticity. And those people admitted they were having to buy marijuana off the street and smoke it. And they were saying, really, if we had it in a liquid form or pill form, it would work just as good.
Right.
So it takes a change of a mindset slowly, and it takes someone with courage, like Representative Click, to be the first one to step out there, and like this gentleman, Senator Menendez, to put it out there again and say, hey, we need to think about this, got to force it.
Got it. Sir.
Yes, my name is Mario Villaseñor. I'm with the neurology program here at UT Medicine. And the question I have is regarding the delivery system reform incentive payments. We talked about some of the issues with funding and so forth. My question is, what is the current status of this particular payment program, and what is the future for the state of Texas to continue with that program?
Representative.
Well, that's kind of what we were talking about a while ago in terms of what's going on with the 1115 waiver that has the uncompensated care as well as the disrupt. And you know, I don't know the answer to that. We're waiting to see. My understanding is that the state of Texas is going to have to be submitting our expansion proposal September, and then there'll be another year before we hear what happens with it. You know, clearly, as I'm sure you know, this is critical to the healthcare delivery system that we've created. I know in the Travis County in Austin, where I am, it's a huge part of what we've been cobbling together to make sure we have more primary care, to make sure we have more mental health care, to make sure that it's coordinated, keeping people out of the emergency rooms for their primary health care. All of those things are at stake here if we have to, if we do not get this extension. So I don't have a good answer for you other than to say I know that it's critical that we recognize that. The legislature did appropriate a little bit of money to show some good faith for some state skin in the game, rather than relying as much on it's still primarily local. But I think the Hospital Association came to us talking about 500 million was going to be needed, and I think we did about 250. So we didn't do what was requested, but we did do something.
Did do some.
So we're hopeful. That's the best I could do.
Sir.
Hi, my name is Abear Lopez. I'm with Masterword Services in Houston. With the changing demographics of the state and a large number of international patients making Texas their residence, do you foresee any legislation that would allow the state or insurance companies to reimburse hospitals and small clinics for the language assistance programs that they're...
Language assistance.
Language assistance.
Right. This is
for interpreters and
one
such.
of the consequences of a state with a fast-growing and dynamically changing population is there may be things we need tomorrow that we don't have now, Representative.
I have something that I passed that seemed really small, but it was a bloodbath nevertheless to get it through, and that is to add to public health curriculum, public ed curriculum, if they chose to do it, to have foreign language offered in a professional or jobs-based format. Right now, I believe that foreign language is basically useless. You learn how to fill in little sheets and translate words, but can you converse? Can you think in it? Can you actually functionally use that language? And so this is something we passed. It's never happened before in Texas. We have immersion programs. Representative Bernal and I spoke to this a little bit. So it's not a mandate, but if a school district chooses to do it, to be able to focus on professional or workplace foreign language, that could be helpful for that purpose. And so, but that's very early on to what this is.
But it's a problem that as the population changes,
Yes.
may become more of a
We'll need
problem
more and more people.
over time.
And you can't necessarily hire an interpreter for every person that comes in. That really technically is your civil right to do so. But wouldn't it be better if everyone has some semblance of being able to converse in a foreign language? Not every language, but specifically the most common one in Texas, Spanish, to be able to have these patients be at ease. And I think the way you start that it could be immersion, and you could go stay in a country for a while and learn it, but that's expensive. So we're trying to look at it a way to maybe tap on the door with regards to public education.
I'm being told it's 1 o'clock and that we are unfortunately out of time. I'm sorry to the people who did not get to ask their questions. We're very fortunate to have had these three with us to talk about this whole range of issues. Could have gone much longer. Please thank Representative Howard, King, and Sheffield. Thank you to the university for having us back, and of course, thank you all very much for coming. Appreciate it. Thank you.